Yes, yes. Yes, he's here.
Okay. Okay. So I would like to start the program. Assalamu alaikum, everybody. Thank you very much for being here today. And we are here today on behalf of Ferosons. And a little introduction about Ferosons. Ferosons Labs is the first pharmaceutical company in Pakistan, and it's providing quality medicines to needy patients. And it is always putting the patients first. They have been serving needy patients and initiating programs to help the healthcare practitioners since 1954 and will continue to do so. Following its legacy, the program of diabetes and comorbidities is conducted every month. And the doctors, the purpose of these sessions is to gain knowledge and information in their clinics and hospitals on their desks without wasting the time for traveling and without going anywhere else. So we are all preparing for Ramadan, and we know that Ramadan is a way to clean our souls and our heart as well. But whenever Ramadan comes, we as a health practitioners are always concerned about the comorbidities that our patients may have and how to manage these comorbidities and to avoid any worsening of these comorbidities. Today's session is especially about heart failure. And so we will talk about how heart failure can be managed during Ramadan and how to avoid its worsening. So without wasting any further time, I would like to invite Dr. Shahid Iqbal, who is a cardiologist, and he will be giving us a presentation on Ramadan and heart failure. So over to Dr. Shahid Iqbal.
Assalamu alaikum. Hello, Uncle, can you hear me? Hello.
Walaikum
Can
Assalam. Yes, Dr. Shahid, you're audible.
Is it? Okay, thank you so much, Kumdiha, for the introduction, and I'm really grateful to the Rosas is our religious obligation and people, especially the topic of today is make them aware and overview of the precautions of the cardiac patient. So let's start with Bismillah. So the first question would be, can a heart patient fast during Ramadan? The answer would be yes. Usually it is not associated with any change in the incidence of the acute cardiac illness, and majority of the patients, they can have safe fasting during the Ramadan if they are asymptomatic and they're not having any acute symptoms. Other question, can you hear me?
Yes,
Can
we
you hear
can.
me?
Yes, we can,
Okay.
Dr. Shahid.
The other question would be, the other question would be, what is the effect of intermittent fasting on heart? You know, Ramadan fasting, it is not harmful for majority of the patients, and you know there have been various studies, observational studies have been done by the European Society of Cardiology and American Cardiology, American College of Cardiology as well, especially on the patient with the chronic coronary syndrome, because majority of our patients, cardiac patients, they lie in the, the category of the chronic coronary syndrome, and many of them, out of them, they are actually having chronic heart failure. So they have observed that 29 to 30% of patients, they actually reported with a significant improvement in the cardiac symptoms. So basically it is beneficial for the cardiac patients if we talk about. And the other will be who should avoid fasting, because this is very important, because we have to counsel the patient accordingly if they have the following conditions, like if they're having uncontrolled hypertension, they are observing refractory angina, shortness of breath at rest, dyspnea on exertion, chronic heart failure symptoms, and if they are having poor functioning of the heart, and they are unable to carry out the routine activities. So these are the patients, and this is the category of the patient whom you should advise to avoid the fasting. Pathogenesis I will not discuss because the idea of discussion is to correlate with the fasting, what the electrolyte imbalance and other hemodynamic changes occur during fasting, because there are four mechanisms, especially the neurohormonal activation, activation of the sympathetic nervous system, activation of the renal angiotensin system, and the other neurohormonal derangement. So these are all derangements. They actually dependent on the volume status and the electrolytes. So electrolytes derangement, it is one of the major factors which can happen during the Ramadan. So that's why it is important to discuss the pathogenesis as well. So just a graphical representation and the possible causes. I will not go into details. We have already discussed with this, because but you should know what are the alarming features, because if it is uncontrolled and patient is having multiple comorbidities, because many of the patients they already having they have diabetes, hypertension, their BMI is elevated, if and they are having anemia, advanced age, sedentary lifestyle and all that. So these all heart failure patient with the risk factors. So you need to be vigilant over this, because ultimately you have to hospitalize the patient, the rehospitalization, the renal insufficiency, hepatic insufficiency, and ultimately the patient quality of life is remarkably affected. So this is general classification of the severity of the heart failure. So class A and B. Class A, as you all know, this is a group of patients with the risk factors. Class B, patient with structural heart disease without any symptoms. So these two categories, these are the patients in whom you can advise, because they lie in the category of the more low to moderate risk. So you can advise fasting. But if the patient presents with the class C, in which they have current or prior symptoms, you have to be very careful. And obviously, class D, it is purely contraindicated as far as the fasting is concerned. The other is NYHA functional classification. It helps the severity of the LV function, because LV function, it is a predominant determinant of the overall prognosis of the and symptomatology of the patient. Patient with class B, will be having heart disease, but they will not be having any physical symptoms uh, which can impair, which can alter their routine activities. So class 2 with slight limitation of physical activity. So in this classification, class 1 and class 2, you can advise fasting, but not in class 3, because in class 3 patient will be having marked limitation of physical activity, and although patient will be comfortable at rest, but whenever he starts, obviously exertion symptom will be elevated. So these are the
Assalamu alaikum. There's a connection issue, and we are going to solve it out. We just need 1 minute.
Okay. Okay, can you hear me well?
Yes, Dr. Shahid, it's now better.
I think there is some technical problem. Hello, everybody. Can you hear me now?
Yes, Dr. Shahid, you're audible.
Okay, I think there was some interruption because of some technical factors. So, presentation. Okay, so intermittent fasting, it is very helpful for cardiac patients because it helps reduce inflammation, and inflammation is something which can provoke the ischemia, and whenever the ischemia is provoked, it ultimately worsens the heart failure. So there are some instruction for the patient who are having some history of intervention, like patient who have done undergone stenting or CABG 1 year ago, and now they are totally asymptomatic and they can perform routine activities without any limitations, and they are having very good compliance. You can safely recommend them for fasting, but not within the 1 year. Such patients who are having intervention, cardiac intervention, 2 months or 6 months, you have to be more careful, because such patients, they are at high risk. You need to monitor them accordingly and regularly. So after 1 year, asymptomatic, you can prescribe, you can advise it. So regular meeting, these are the factors you have to be vigilant about these. The first one is the fluid status, because in Ramadan we have noticed that fluid status, people uh, take plenty of water, and ultimately they can go into volume overload. Electrolytes, they are totally deranged in this condition. Anemia, current illness, if patient is having some sort of illness, and if obviously compliance, it is another factor. So these are the, I think, five major factors which we should keep in mind, and we have to be very vigilant about the pharmacology. So if these parameters have to be in mind whenever you advise cardiac patient fasting. So I will not go into details because a long list of heart failure etiologies. So ischemic cardiomyopathy, idiopathic, familial, restrictive, valvular heart disease, hypertension, and all that. But I will not go into details. But you should discuss. I'm only concerned with the nutritional deficiencies, right? Iron, thiamine, and selenium deficiencies, and all that. So whenever nutritional imbalance is there, electrolyte imbalance happens, and it can help the worsen the heart failure. So it is also important. Following are the signs and symptoms which physicians know, and they should aware their patient, because patient should know that dyspnea, it is the earliest presenting symptom, and when orthopnea happens, that means heart failure more worsen, and it is the most specific, especially fatigue, exercise intolerance, abdominal pain. So these are all the non-specific symptoms which can alarm the physician that the patient is having heart failure and is observing the current symptoms. So here is a slightly slide is slight crowdy, but it's very important because we have to risk stratify the patients for the fasting. The first category is the low risk or the moderate. Here, these are the number of patients in which you can advise fasting. Number one, the fast, stable hypertension, stable angina, ejection fraction more than 35%, or heart failure with preserved ejection fraction, means heart failure with ejection fraction more than 50%. Patient having implantable loop recorder, permanent pacemaker, mild or moderate valve heart disease, supraventricular tachycardia, atrial fibrillation, and sustained VT or VT and all those. These are the patients in which you can go for prescribe the fasting. Well, the other is the high risk of patient in which you should advise to refrain from fasting. It is the poorly controlled hypertension which is not controlled, recent acute coronary syndrome, hypertrophic obstructive cardiomyopathy with obstruction, severe valvular disease, severe heart failure without advanced features, poorly controlled arrhythmias, and high risk of the fatal arrhythmias and all the implantable loop recorder with the if simple loop recorder is there, you can prescribe you can advise fasting, but not in patient with the ILR with resynchronization therapy. And then a certain category, it is these are the patients who are having very high risk, advanced heart failure and severe pulmonary hypertension. So fasting will be absolutely contraindicated. So risk stratification is very important. You have to go get a complete history and examine the patient and then risk stratify accordingly. So these are the few pre and post Ramadan checklist for reviewing the patient with the cardiovascular condition. You have to establish the patient background, previous Ramadan fasting, how was the experience, what was the symptom status, smoking status, cardiac and other medical history, and what was the medication, and how was the patient compliance. These are all the factors which can have the patient background, because you will get an overall idea that what category of patient is this, and is it the low risk or the moderate and the high risk, right? Then you have to review the recent investigation, recent electrolytes, ECG, imaging, echo, or any other intercardiac device. You have to go for the interrogation of the device if it is patient having pacemaker or implantable loop recorder. Then you have to re-stratify the patient, communicate with the management, right? Obviously, re-stratification refer to Ramadan, and CKD or diabetologists communicate the risk and provide. You have to completely tell the patient what are the risks of the which the patient can observe during fasting, right? So general Ramadan advice is healthy diet, fluid intake, smoking breaks, fasting, opportunity for smoking cessation, as I already mentioned. And the other is the terminate fast if feeling unwell. You have to aware the patient that if following symptoms happen, you can terminate the fasting immediately. So intramuscular injections and sublingual medications, they do not break the Ramadan fasting. It's also very important because patients are very concerned about the medication and all that, right? And the other is post Ramadan review. You have to explore the experience of the patient of the Ramadan, and then based on the symptomatology you can guide further. And this is another proudly slide which will help you to understand the overall risk stratification. Does the patient intend to fast? Yes, the patient willingness is very important. If the patient is not willing for the fasting, obviously you will continue the medication. And if he or she is willing, you have to risk stratify the patient. And for that, if the patient is low to moderate risk, you can recommend fasting without any fear. But is the patient take cardiac, where you have to look for the medication compliance and the recent investigation of the patient, which can help you assess the overall risk of the patient, right? And the risk management is you have to counsel the patient about the dehydration, fluid overload, electrolyte abnormalities, and nutritional requirements. These four factors, these are very important, because these are the derangements which patient can experience during that. And advise the patient a 6-day rule. If the patient is sick, he or she should be advised to terminate fasting immediately, and consider trial fast. And such patient you should advise, they should practice fasting before the Ramadan, like they can practice fasting during Shaban, 15 days before the start of Ramadan. If they experience well and they're not having any symptom, obviously you can prescribe, you can advise fasting as well, right? The other will be high risk and very high risk. You already know you have to, in very high risk, it is absolutely contraindicated, and the patients are with the advanced heart failure and the severe pulmonary hypertension. And if the patient is high risk and patient still choose to fast, what are the alternatives? If you non-consecutive fast, you can advise intermittent fasting, fast shorter days. If the winter the weather is reasonable, then you can advise it. But if the weather is extremely hot and there is a chances of dehydration, you should counsel against the fast, right, in the interest of patient. And And the other, if the patient declines and is unsuitable for alternatives, then obviously you have to check the overall health status of the patient, and and document each and everything, right? Risk management is important. Advise patient to speak to local scholar about the decision, because this is a religious obligation. It is not the responsibility of doctors only, because you have to sometimes engage the religious scholar as well, because their opinion is also very important. So in this way it can help you counsel the patient well for the right. So 6-day rule is very important. How when to terminate the fasting, when to start fasting, and when to avoid fasting. These are all risk comes under heading of risk stratification. So there are certain precautions for the cardiac patient. These are overall general precautions. The number one, as I already mentioned, it helps quit smoking. 30 to 60 minutes of physical activity, which is recommended for the American College of Cardiology. It should be at least mild to moderate levels, right? Obviously, I will not. We should not prescribe the. Advice for the vigorous activity. They have to be in the mild and moderate, and 30-60 minutes is fair enough. Eat heart healthy diet, maintain a healthy weight. Obviously, weight reduction is a very important part of the management of heart failure. Good quality of sleep is important, because sleep, it is somehow disturbed and the routine is changed. So you have to ask the patient to at least have a 6 hour stat deep sleep, right? And you have to manage the stress as well. Regular health screening is important. And as far as salt is concerned, patient, it has been observed that people use more salt in the form of snacks and samosas and all that, right? In Ramadan, so which are strictly prohibited. They can't take more than 1 teaspoon of salt a day, right? So eat more fiber. Fiber is very important, and they can get fresh fiber from the fresh vegetables, fruits, and whole grains. And obviously, they have to avoid overeating. Yes, this is another very important, because people used to, overeat, and that's why in their angina or heart failure, it is provoked. So always, advise them to have a, not avoid overeating. So that's all. And I'm really grateful to the Frosens for this great learning initiative. And if you have any question, I'm here to answer. Thank you so much.
Thank you very much, Dr. Shahid. That was a very elaborate presentation, and I guess the audience will have a lot of questions. But before moving on to the question and answer session, we will have our second presentation. So do we have our
Right.
second speaker with us, Dr. Rehan Riaz, sorry?
Yes, Dr. Maliha, he's here.
I think he hasn't shared his screen yet.
Yes.
Assalamu alaikum and hello to everyone.
Yes, ma'am.
Can you hear me?
Dr. Rehan Riaz is an interventional cardiologist at Faisalabad Institute of Cardiology, and he will be our second presenter. So welcome, Dr. Rehan Riaz, and over to you.
Thank you very much. Excellent presentation by Dr. Shahid, and he has covered the major subject. And I'll just add some points into it. I'm just sharing my screen, and it will be, I think, available in a few minutes. I think you can see it now. My screen is visible to you?
Yes, Dr. Rehan.
Yes, that's great. That's great. So, welcoming the Ramadan, and it is a good opportunity to be back to the healthy lifestyle. It is a good opportunity to get your weight to the normal limit, to have a better dietary habits, and it's an excellent opportunity to stop smoking as well. Coming to heart failure is a global burden. We have 60 million people worldwide who have heart failure, and is the number one reason of hospitalization patient is greater than 65 years, with 24% of the patient rehospitalized within 30 days of discharge. And approximately 50% of patients diagnosed with heart failure will die within 5 years. And we are 1.8 billion Muslim living in the world, and they are fasting. So we have a number of patients with heart failure who are Muslim, and who need to fast, who wish to fast during Ramadan. So what about heart failure in Ramadan? This is the main topic of the discussion, and Dr. Shahid has excellently elaborated major of he has done justice with this subject, and I think I'll quickly wrap it in about 5 minutes. So Ramzan, this is what Ramzan is, and the verse quote that, "Oh, you believe who you believe fasting has been prescribed to you as it was prescribed to those before you, so that you attain taqwa." So fasting was there in previous religions, and still many Christians and Jews follow the fasting. But a uniqueness of Islamic fasting is that it is a voluntary rather than being ordered by a physician. There is no selective food intake that is protein only, juice only, as in the other religions. They permit only, like in some religions of like Christianity, they promote allow only juice or fruit only in during fasting. And there is no total caloric malnutrition. It is not a semi-starvation diet, and exercise in itself is to promote discipline, that is from constant nibbling, drinking, and smoking, etc. And then it is a blessed month, that is you can feel the motivation by additional praying, and psychological effects are there. And it before fasting, general advice for those who fast is that consult your Muslim doctor first, and then, as elaborated by Dr. Shahid, that first practice of fasting in the Shaban first. It will give you a good deal that whether you can fast or not. And with the approval of the physician, switch to either long-acting or twice daily medication, so that the medicine that are taken in the at 12 o'clock or 2 o'clock may be avoided. And there is a list of patients who cannot fast. These are the admitted patients that are physically sick patient, and who are on journey. And then a woman during menstruation, pregnant electric woman can then quit their fast. And then their fasting is only for pubertal person. Some effects of fasting: you can have a weight loss of 1.7 to 3.8 kilogram, and there is decrease in appetite due to ketosis and increase in beta endorphins that make you happy. And there are fewer suicide in Ramadan. A study in Jordan reported it. And no change in outcome of pregnancy or in birth weight in those who fasted and those who did not. That was reported in Gambia. So let me share you my case study. And case study is that a female, 68 years of age, having weight of 66 kilogram, having normal blood pressure, had a heart rate of 82 per beat per minute, and creatinine was 1.2 milligram per deciliter. He was a known case of heart failure with reduced ejection fraction due to chemotherapy. She had a history of chemotherapy, breast cancer, and the risk factor was hypertension. Patient is still in NYHA class 2. She has no angina, no orthopnea, no PND, or no swelling. And her current medication are: she is on aspirin, she's on spironolactone, she's on carvedilol 25 milligram BD, she is on enalapril 5 milligram BD, and she takes furosemide 20 milligram daily. So first of all, if a patient of such age and such symptoms comes to you, so what next should be done to this patient? In terms of medicine, I think for mortality benefit, she should be on RNA. So we stopped his ACE inhibitor for 36 hours, and then we started scubitalvalsartan on 100 milligram PD, and she's tolerating well. And then the other class of the drugs in which she should be having these are SELT2 inhibitors. So these are the two class 1 recommendation that she was not taking, and we started the patient on RNA and SELT2 inhibitor, and for mortality benefit only. And the patient has symptoms NYHA2, and she's having a better quality of life now. Now Ramadan comes, and she comes to you with the advice of getting fasting or not. So what should be done now? So if you look at the list who cannot fast, that are acute heart failure, that is the patient with acute pulmonary edema, cardiogenic shock, and severe systemic congestion. The patient who has stable heart failure, that like she is having ejection fraction 35%, she has a NYHA class 1 or 2 symptoms. So she is asymptomatic, she has stable hemodynamics. So just adjust dose of drugs, give her the relevant advice, and they are already long-acting drugs. She is on once-daily drugs, and we can limit the use of diuretic, because ARNI and SGLT2 has some diuretic effect also. So if you look at the guidelines, the few studies in patients with non-severe heart failure with reduced ejection fraction, whom would deem as low moderate risk, undertaking Ramadan fasting suggest that it is safe them to do so, in line with the guidance from British Heart Foundation and ESC. Heart failure with preserved ejection fraction is another entity which has not been studied yet, but the same rule applies that stable patients with heart failure with reduced ejection fraction can undergo fasting, and if the patient is in hospital or if he's having acute LVF, then he should avoid fasting. Some thing to for drugs, angiotensin receptor neprilysin inhibitor may worsen fasting associated hypotension, which may result in dizziness or loss of consciousness. So we may have to reduce the dose, may compound fasting associated dehydration, resulting in acute kidney injury and life-threatening electrolyte abnormalities, for example, hyperkalemia. And the medication non-compliance was the #1 reason of the fasting patient to get compromised. So in the studies, a study done in Saudi in 2018, they studied the heart failure patient, and 92% patient remained asymptomatic during fasting, and the 8% who were symptomatic during fasting, medication non-compliance was the main reason. So again, talking of the beta blocker that she was taking peak cardiolol 25 milligram BD, they again they can cause fasting hypertension, which may result in dizziness. And again, beta blockers should be continuous. There should be no drug non-compliance. Diuretics, again, we have to reduce the dose of diuretic, because fasting itself causes dehydration. And then, as Dr. Shahid has already mentioned, that we should limit the intake of water during Aftari and Seri. So, and salt intake also. And then SGLT2 glucose inhibitors. I think these are the drug of choice in diabetic patient, but one should be very careful about the fluid intake during SGLT2 inhibitor. So they may worsen fasting associated hypotension, and they can cause fasting associated dehydration, and a reasonable quantity of fluid intake should also be given. So this is what is there for me, and the topic is open for discussion. And I again thank you very much for such a healthy activity. So thank you very much.
Thank you very much, Dr. Rehan Riaz. That was a very elaborate talk, and both of our speakers have really enriched our knowledge about heart failure, especially during Ramadan. And now I would like to take some opinion of our expert panel. So do we have Dr. Imtiaz Hassan with us?
Yes, Assalamu alaikum.
Yes, Assalamu alaikum. So, a brief director of Diabetic Institute of Pakistan, Lahore. Sir, heart failure cases are much more prevalent among patients with diabetes. And so would you like to add on to something as our experts have already discussed?
So I think this is one of the topic most discussed nowadays, because this heart failure and diabetes, they have the bi-directional relationship. So first of all, if you have diabetes, you have more chance to have the heart failure. If you have heart failure, you have more chance to have the diabetes. So it's the other way around. So basically, with the advent of this empagliflozin and the SGLT2 inhibitors, the total scenario, the management of the heart failure has been changed. So we have certain landmark trials like the EMPA reduced trial, EMPA preserved trial. So they all have shown the beneficial effects of the empagliflozin. The most simultaneously, we have seen that the role of empagliflozin it's quite scary for the general practitioner to start during the Ramadan, because they are probably they have the fear of the dehydration during the period of Ramadan. So I think they can be safely used as SGLT2 during the Ramadan if the patient is of the heart failure is using it, or the diabetes is using it. The reason is that they have been proven efficacy during the Ramadan as well. But we must keep in mind the one precaution that I switch all of my patients who are taking SGLT2 inhibitors at the iftar time. And if there is no contraindication, I advise them to take the plenty of the fluids. But as the patient is a heart failure, obviously you have to keep in mind certain precaution. The fluid intake limited. You have to limit the fluid intake and the salt intake as well. So they are the drugs which can be safely used in the heart failure and during the Ramadan. And but the SGLT2 inhibitors, they have definite role in the management heart failure, both in with the preserved ejection fraction and with the reduced ejection fraction as well.
Thank you very much, Dr. Imtiaz Hassan. That was it is really important to mention the trials that have changed the management of diabetes as well as heart failure. And then these trials have shown us another way to help the patients who have a preserved ejection fraction. And before the SGLT2 inhibitors, we did not have much choice. So our next panelist is Dr. Riaz, who is a cardiologist from Bolan Hospital, Quetta. So would you like to add something?
हेलो अस्सलाम वालेकुम
Yes, sir.
जी आवाज आ रही है मेरी
जी sir, we can hear you.
ओके सो बिस्मिल्लाहिर्रहमानिर्रहीम सबसे पहले तो मैं फिरोज का शुक्रिया अदा करता हूँ उन्होंने मौका दिया है कि रमज़ान भी आ रहा है और उसके साथ साथ हार्ट फेलियर के मरीजों के लिए क्या हम एडवाइस कर सकते हैं। तो ऑलरेडी जो स्पीकर्स उन्होंने तो बहुत अच्छी स्पीच कर ली हैं, बहुत अच्छी बातें बता दी हैं। बस ये ऐड यही करना है कि रमज़ान में जो है जो हार्ट फेलियर के मरीज़ हैं उसमें हार्ट फेलियर को तो ऑलरेडी बहुत डिटेल से डिस्कस हो चुका है कि उसमें रिड्यूस एजेक्शन फ्रैक्शन और प्रिजर्व एजेक्शन फ्रैक्शन और मॉडरेटली रिड्यूस एजेक्शन फ्रैक्शन के साथ पेशेंट होते हैं। तो उसमें जो प्रिजर्व एजेक्शन फ्रैक्शन वाले पेशेंट हैं या जो स्टेबल हार्ट फेलियर के पेशेंट है वो तो इजीली फास्टिंग कर सकते हैं, उनमें कोई उनको मसला नहीं होता। लेकिन जो पेशेंट अनस्टेबल होते हैं, जो क्या नाम है IV ड्रग्स पे होते हैं या जो डिकंजेस्टेड डिकम्पनसेटेड हार्ट फेलियर के होते हैं या जो एडमिटेड पल्मोनरी एडिमा वाले पेशेंट होते हैं, तो उनको तो फिर फास्टिंग अपनी क्विट करनी पड़ती है। तो फास्टिंग वैसे एक बहुत अच्छा मौका होता है हार्ट फेलियर के मरीजों के लिए कि वो अपनी डोज को भी दवाइयों के एडजस्ट करें और अपनी डाइट वगैरह को भी बेहतर करके अपना वेट भी मॉडरेटली रिड्यूस करें। क्योंकि रमज़ान में ये देखा गया, जैसे डॉक्टर रेहान रियाज की स्लाइडों में भी था, कि मॉडरेटली रिड्यूस करता है वेट को और वेट रिडक्शन हार्ट फेलियर के मरीजों को बहुत फ़ायदा देती है। इस तरह डायबिटीज़ के पेशेंट होते हैं वो भी अपनी शुगर वगैरह को बहुत अच्छा मेंटेन कर लेते हैं। तो मेरी तरफ से तो यही है कि ऑलरेडी जो है 2 पैनल स्पीकर और एक पैनलिस्ट ने बहुत अच्छी वो बात कर ली है। बाकी वही जो 4 पिलर और उसके मैनेजमेंट के ऊपर बात है वो तो बार बार रिपीट होगी। तो मेरे ख्याल में ये बहुत अच्छी डिस्कशन और हेल्दी डिस्कशन रही है हार्ट फेलियर के पेशेंट के लिए। जी थैंक यू जी।
Thank you very much, Dr. Riazuddin, for your expert opinion. So with this, we will like to end our session. And I hope that all of us have a good Ramadan with good health and blessings of Allah. And our next session will also be based on heart failure. You will be asked to join again. Thank you very much. And we are concluding the session. Allah Hafiz.